Dr. Dilraj Sokhi is a consultant neurologist and head of neurology section and assistant professor in adult clinical neurology at the Aga Khan Nairobi Hospital, Aga Khan University Hospital, Nairobi. He trained at a tertiary center for neurology in Sheffield, UK for 10 years, and his main interest is epilepsy, but I think he's seen quite a bit of diabetic neuropathy as well. So I'd like to invite him, and he's tasked to handle the topic neuropathy, pragmatic approach in patients with type 2 diabetes.
Good afternoon, everyone. Thank you very much, first of all, to the organizers for the opportunity to grace the stage. I realize I'm between now and lunch, so it's a very critical stage of the day. So I hope I can keep you enthused. Unfortunately, I try to keep the audience interacting throughout this presentation, so you will have to raise your hands or shout some answers. I wanted to make this an interactive learning session with an automatic clicker, but when I heard that there was more than 50 people coming, I didn't have enough clickers, so I couldn't do that. But it's amazing how many people we have in this meeting, and I think it's a great opportunity to learn from as well. So, peripheral neuropathy is a common problem, and certainly it's very relevant to diabetes. So I'll start off by just giving a bit of background on peripheral neuropathy. It's very common. Can be as much as 8% in the older age group in the population. Diabetes is the most common cause for what we call a distal symmetrical polyneuropathy, and I'll explain that a bit more as we go on. Over half of all neuropathy patients have diabetes as well. Okay, so it's a strong association. And the complications you get from the distal symmetrical diabetic neuropathy has many disabilities, both from pain, but also other complications, foot ulcers, amputation, falls risk. I'm sure you'll be covering most of these in the rest of the talks. Now, when a clinician, physician, or indeed any other healthcare professional is confronted with a patient who may have a bit of a tingly hand or tingly feet or painful toes or whatever it may be, there are 6 questions that we need to ask in order for you to work out what could be going on, and I'll just walk you through these. So what systems are involved? So the nervous system is very nicely categorized into different systems. Is it motor? Is it weakness? Is it sensory? So pins and needles, numbness, pain, temperature, intolerance, etc. Is it autonomic? Or is it a combination of those things? That's the first thing to gather from the history. The second thing is, what is the distribution? One hand, the other hand, both hands. One foot, the other foot, both feet, starting in the thighs and worked down, etc. So what is the distribution of the weakness? And is it distal versus proximal? One side, asymmetrical or not? And if the sensory involvement, it's a similar thing, but in addition, you need to work out what kind of sensory symptoms they have. Is it pain or burning loss, sensation? Is it proprioceptive loss? So they're having a shower, they close their eyes and they fall, although that sometimes happens to me. And is there any evidence of an upper motor neuron involvement? And this is a key symptom and sign to look for because it changes the whole direction of thinking. There is one condition that gives you both low motor neuron symptoms and signs and upper motor neuron signs. Can anyone shout out what that is? Motor neuron disease is the most important one, yeah? So that's the one we need to think about. But you don't get sensory symptoms of motor neuron disease, yes, remember that. And again, what is the temporal evolution? How has this patient's symptoms evolved? Is it chronic over several months? Is it acute over a few weeks? Or is it in between? So subacute, a rough figure is sort of between 2 and 3 months is about subacute. Yeah? Acute would be anything before 4 weeks. And then is there any evidence that this is familial? Does it run in the family? How does it run? Do a pedigree tree? Yeah, are there any associated features that they need to think about? Skeletal deformities, pes cavus, etc. And that's important to know. So this is a bit of a busy slide, but it's just to show how those questions can then fit into different patterns of neuropathy that can then help target what you're thinking about. So if you look at so pattern A, so there's no upper motor neuron involvement. It's combined, symmetrical. And you start thinking, but it has happened quite reasonably quickly, and you start thinking about acute inflammatory or subacute inflammatory demyelinating neuropathies, or CIDP, etc. And diabetes can fall into that. I won't go into the rest of the patterns. There's about 7 different patterns, but this is just to show that those 6 questions can help direct where you need to think. I can share the references with you later. So, case-based discussions. This is what I like. We'll start with this first case. It's a bit of a trick one. So, 56, diabetes for 4 years. 6 months of numbness in the right hand, which is a dominant hand, but it doesn't involve the little finger. And when you examine her, she's got numbness in that lateral part of the hand, and she's got a weak abductor pollicis brevis. So, shout out to diagnosis. Okay, everyone's voice is going down. So I'm going to go for carpal tunnel syndrome. Okay, so simple things: dominant hand, secretary, types a lot, always stressing on the wrist, which is diabetic. The associations of carpal tunnel with diabetes is well known, but it's associated with many other conditions, as I've shown here. Yeah, so this case is called carpal tunnel syndrome, and you can diagnose that based on the history and based on the examination. So you look for the median nerve involvement, and the floor muscle supplied by the median nerve is the mnemonic we use is LOAF, which is the lateral two lumbricals, opponents, abductor pollicis brevis, and the flexor pollicis brevis. Weakness in those muscle groups suggests it's a median nerve palsy, and typically the sensation loss spares the little finger. You have a friendly neurophysiology technician. You can send them along for carpal tunnel studies, as you can see there, but although most neurophysiology technicians are friendly, there are not many of them around. So they are the tests you can do clinically. So there's a closed fist sign, where you ask them to make close the fist and then open up again. But I think the ones you're probably more aware about is the Fallon's test, which is you ask them to hold their hands like this for 60 seconds, and then you ask them to open their hands and they can tell you whether there's numbness and pain down in the distribution. Tinel's sign, where you tap in the carpal tunnel like that and see what happens. But there's various other tests, but those are the 2 we normally use for diagnosing carpal tunnel syndrome. Okay, so that's just an introduction to the different types of neuropathies you can get in diabetic neuropathies. And this is a way to classify them. Symmetric and diffuse versus asymmetric and focal, the different types. I just want to highlight that those 2 there, so treatment-induced diabetic neuropathy and diabetic cachexia, are usually acute, so they happen usually in a few weeks. And the other 2 there as well can happen rather acutely, but not over weeks, usually over months. So another way to classify these diabetic neuropathies, apart from symmetry and the area that they affect, is also whether it's acute versus chronic. So, case 2. A bit more standard, 70-year-old man, comes in, says he's got numbness and tingling in his feet for 2 years, feels like a burning pain, like a bee stinging him all the time, and his feet stay blue and cold all the time as well. When you examine him, as I'm sure all of you do a full neurological examination of all these patients, like I do, the strength is completely full in all the muscle groups, including the toe flexes, because the toe flexes are the ones that usually go first. The deep tendon reflexes are completely normal, but you do find that there's decreased pinprick up to the mid-calf, so stocking distribution loss and reduced vibration sense of the big toes, and he has a raised HbA1c. So, what's the diagnosis here? Yeah, so it's going to be this is a typical case of diabetic distal symmetrical polyneuropathy. Yes, this is the common case. So, most common form affects more than 50% of all diabetic patients. Most of them do have significant pain with it. And having neuropathy increases the risk of ulceration quite a lot, contributes to the risk of lower extremity amputations. But importantly, people with diabetic neuropathy, they fall, showers, etc. Yeah, they proprioceptive loss, but many other things. There's some evidence from trials, and I'm sure this may have been covered in other talks, the DCCC trial that showed that if you do control diabetes properly, that reduces the risk of the clinical neuropathy. And the follow-on study from that, the EDIC study that continued to follow up the DCCT patients, showed that those patients who were intensively treated were less likely to get neuropathy 14 years later. So diabetes control helps in preventing neuropathy. The kind of neuropathy you do get is usually a small fiber neuropathy. Now, the nerves that we have, there's 2 main ones, large fibers and small fibers. And the small fibers are these small, narrow diameter myelinated A delta fibers and the unmyelinated ones. Both of them pass through the dermis and innervate cutaneous structures up in the skin. The A delta fibers lose their myelin sheath when they go through the dermo-epidermal junction. And they mainly for cold and nociceptive input, that's pain, and other sort of mechanical and thermochemical stimuli. And this is just a electromicrograph with some staining. So on the left, it shows this is a skin biopsy. On the left, they stained for myelin with green and for the nerve endings with red. And the white arrows point to the nerve endings, which are from the small myelinated fibers, but you still also get the larger myelinated fibers there. And the slide on the right shows pictures of the different nerve fiber types. So the blue arrow shows a large myelinated fiber, the big ring around it. The pink arrow is a small myelinated fiber, so that's an 8 delta fiber. And then the one in the red arrow is the unmyelinated fiber. Okay, so if anyone ever has to answer a question on histology, that's what you need to think of. But aside from diabetes, people who come with these painful neuropathies can have a host of other things that could be causing these symptoms. Yeah? So insurance companies will probably not be happy with this list if you're going to investigate for all these different types of things. But diabetes is by far way up there. But importantly, just above diabetes is the impaired glucose tolerance, and I'll come to that in a minute. There are other things to consider, and particularly infections and drugs in our context that could be contributing to this, and then immune-mediated, which is a sort of vascular type of neuropathies. And I'm not going to go into them in too much detail, but just know that there can be many, many causes for these neuropathies, and you have to keep your mind open about them, which is why neurologists exist to help you. So, what does this peripheral neuropathy involve? It's usually sensory symptoms in the feet, and then they progress up approximately. It's called a length-dependent process. Length-dependent meaning the longer nerves get affected first, and the longest nerve we have in the body is indeed the legs that go to the nerves that go to your legs. So they get affected first, and there's a diving back phenomenon in the end, and then the arms can start getting affected, which is why then you get this glove and stocking pattern of sensory symptoms and signs. And pain is usually the presenting symptom. It can be very severe and can be evoked. These patients say, I can't tolerate bed sheets being on my toes, or indeed wearing socks and things like that. And on examination, as you did see in the case example, there are various signs you can pick up. Reflexes can be intact. Having normal reflexes does not mean you don't have a small fiber neuropathy. Okay? And you need to examine each sensation, the light touch, the vibration, joint position sensor, usually also those tend to be normal. However, you will get a change in thermal sensations, so you see something that's a bit cold, like a tuning fork, or if you just touch with a brush, it feels extremely painful. The key part of the diagnostic evaluation for a standard length-dependent symmetrical glove and stocking neuropathy that is chronic is essentially, one, look for diabetes, HbA1c, etc. Do your basic test group for vitamin deficiencies. Okay, so this gentleman could have had a full blood count, electrolytes, LFTs, etc. But out of this list, is there any other 1 or 2 tests that we must check for in all these patients? Shout out someone. I become deaf. Sorry? So B12 is there, that's the hematinics, B12 and folate. Yeah, okay. I'll put you out of your misery. Sorry, I've got someone on the screen here. HIV. Yes, absolutely, HIV. Now that's, I've done a study on HIV and in acute neurology, and yes, HIV should be in there. Excellent, so I'll add that to my list. Very, very important in this part of the world. But what else? Lipids, yeah, so cholesterol, the only way neuropathy is going to be affected by cholesterol, from what I understand, is usually when you use statins. So statins are a risk factor for getting a small fiber neuropathy, and indeed hypercholesterolemia causes a small vessel vasculopathy. But apart from lipids, anything else?
Hepatitis.
Okay, so infections, yes, I'll take your point. Hepatitis B and C. Although again, cryoglobulinemia with hepatitis C is a very different kind of picture. Not top of my list. Maybe in the context of HIV, yes.
Connective tissue?
No, I'm not going to do a connective tissue screen on everyone with this. Yeah. So some people sent off a dsDNA or an ANA, but it's not my first set of tests. This is a standard person with several months or years of peripheral neuropathy. Yes.
Alcohol.
Okay, so that's in the history.
Use.
Yeah. So that's in the liver function. You can pick that up. Yes.
Yeah.
Treatment with anti-TB drugs.
Okay, so drug use, you'll get that from the history. That's fair enough. Yeah, so I'll just go back to the list I gave you. Yes, so all the things are listed there, I agree. But what else can you test for that is usually missed? I'll put you out of your misery. Yeah, so you need to look for impaired glucose tolerance, and that's what I was alluding to. So pre-diabetic associated neuropathy. Yeah, you don't have to have diabetes to get a neuropathy, so you must check this. So 1 in 5 diabetes patients have a neuropathy at the time of diagnosis, which means something's happening to the nerves before then. Okay, and you do know that people who have an idiopathic neuropathy You test them for impaired glucose tolerance, and it is confirmed. And pain is very common in these people as well. Okay, so always do an oral glucose tolerance test in these people, even if the HbA1c or the glucose levels are normal. Always do this. Any other test. Okay, so this is always forgotten. Always check the serum electrophoresis, ideally immunofixation, because paraproteinemia associated with myeloma, POEM syndrome, amyloidosis, etc. Some of them are indeed treatable, okay, and some of them associated with antibodies for which you can give immunosuppression. And you need to work these people up with a hematologist, yeah. And so send a serum protein immunofixation or an electrophoresis and a urine from Benston's protein on all these patients with a symmetrical neuropathy. In terms of management, pain relief. What is everyone's favorite drug for neuropathy pain? Pregabalin is top of the list. Yeah, drug companies are extremely happy with this. However, there are some guidelines that suggest tramadol is also useful. This is a systematic review that came up recently, and there's the level in A and B recommended treatments, and pregabalin's up there. So pregabalin's what we use. Gabapentin is not as good, but there are a few other things you can use. Duloxetine is an excellent drug. Start at 30 milligrams once a day and go up. Tramadol is there as well. I really try to stay away from the other opioids. So tramadol, duloxetine, pregabalin, top of the list. Yeah. Capsaicin cream is sometimes used in people. It's essentially the pepper cream, yeah, which you should not rub in your eyes or other sensitive parts of the body because it will just be extremely painful. But it can be used for people who are very specific, for example, just painful burning sensation in the toes. Okay, but there's other drugs here that you should not use. Okay. Yes, go on.
What about alpha lipoic acid and gamma linolenic acid with the bees?
Yeah, so
complementary.
Yeah, so that's an excellent question. There's some evidence that may work.
Yeah.
I'm not sure about randomized controlled trials that show that they work better than the other agents in terms of symptomatic relief. I mean, there's a lot of people who also band about neurorubine and stuff like that that says do nerves get better when you take these. But it is an up-and-coming area. Yeah, absolutely. But it's not something I routinely advise people. Yeah, but in small fiber neuropathies, it's something I consider. Okay, so it's called alpha lipoic acid. Yeah. And the other bit is, what was the other bit?
GLA.
Yeah, GLA. Okay, thank you for that input. All right, so moving on to case 3. I hope the pace is fine. I'm aware of time. Yeah. Okay. So case 3, 56, type 1 diabetes for 34 years. Also got retinopathy, peripheral neuropathy, and chronic kidney disease. Comes with persistent symptoms of postural hypertension, but also fatigue, weakness, anorexia, getting nausea after having meals, and constipation. Finds that his socks are always dry, he's never sweated for a while, no sweaty palms when he's anxious, but he sweats profusely on the face and chest, has erectile dysfunction and hypersensitivity to bright lights. And the investigations you do, this is the giveaway, you do some sweat responses and they're all abnormal, he doesn't sweat properly, and you do some cardiac monitoring as well, and there's attenuation of the cardiac response to deep breathing, so there's some dysfunction there. What's the diagnosis here? So diabetic neuropathy, that's quite easy. I gave the full house of symptoms there. But it's under-recognized. It can happen in quite a few diabetic patients. Different studies give different rates, 6 to 20%. And you do this thing called pseudomotor testing for sweating, which is usually abnormal. And interestingly, they're already abnormal in quite a number of newly diagnosed diabetics already, so it happens quite early on. There's an associated elevated risk of death due to cardiac involvement. You just have to talk from Dr. Barraza about that. But other disabilities come from erectile dysfunction, up to a third of these people, gastroparesis, and the failure to know about hypoglycemic attacks. Some treatments you can use for erectile dysfunction, quite easy. Gastroparesis, I will talk about it, orthostatic hypertension, so non-pharmacological and pharmacological. People like midodrine and fluorocortisone, I've not decided between them, but they're what we can use. Right, fourth case, 63, type 2 diabetes for 5 years and hypertension. Sudden onset double vision or waking up this morning. He's got a bit of eye pain around that side as well, and no other neurological symptoms. He's clearly seen a neurologist already because they've ordered an MRI brain scan, because that's what we do, we just order MRI brain scans in everyone. But on examination, that's what he has. So, what's the diagnosis here? Oh dear, Nancy Cunha says it's a lateral rectus palsy. So looking at this man who's looking straight at you, you can see that the left eye is looking down and out. Yeah? So what does a down and out eye mean? Yeah, so it's oculomotor palsy. Yeah, because the unopposed movements of the lateral rectus that makes the eye go out and the superior oblique then makes the eye go down. Those are now unopposed because the oculomotor nerve is affected. The eye looks down and out. But what else do you notice with this man's pupil? It's dilated. So that's an important critical thing. Yeah. So what does a dilated pupil in the down and out eye mean? You think about aneurysms. Yeah. Because of the ACOM aneurysm that just loops around where the third nerve comes up from the brainstem. Happily, the neurologist has already ruled it an aneurysm. And so this man, yes, does probably have a diabetic oculomotor palsy. Yeah. Usually acute, can get some pain around the eye, and you get the paresis of the muscles involved. Some people also get ptosis when you get the Mueller's muscle affected of the eye, usually microvascular ischemia. Interestingly, pupillary involvement can happen in quite a number of people, and it can be bilateral. So, yes, you need to exclude an aneurysm, but even a dilated pupil in this context can still be a diabetic oculomotor palsy. Just like this nerve, other nerves can also be affected. Your fourth nerve, your sixth nerve, and your seventh nerve. And in fact, diabetes is the commonest cause for an isolated fourth nerve palsy. What's the other commonest cause? Head trauma. Yeah, this is the thinnest and longest nerve in the brain. And the person who has a trochlear nerve palsy, how can you tell them when they walk into your clinic? They're walking like this. Yeah, because the trochlear nerve makes your eye extort, so you have to correct it, and it goes like this. Neurology is so fascinating. Cranial neuropathies and diabetes tend to improve and may resolve slowly over time.
What about TB, Sokhi, in the long nerve, like someone this?
And so an isolated TB, yeah, I mean, you'd expect to see some contrast enhancement from the MRI scan. Okay. Yeah, because yes, it does involve the basal skull processes, so that's one thing to consider. But in this context, with nothing else to go on, it's good if you can go for that. Yeah, okay. Right. So fifth case, 57. So poorly controlled type 2 diabetes, HbA1c is just terrible, started on insulin. And 1 month later she comes back to you with tingling and severe burning pain in her feet. When you examine her, she's got reduced pinprick and temperature sensation to above the ankles, and she's got absent ankle reflexes, but her strength is completely normal. And as the weeks go on, the pain and the allodynia progresses to involve also her arms. You tried various medications, including your pregabalins and your tramadols, and they don't work. In the first few weeks, but over the ensuing few months, it slowly starts to get better and she improves. Diagnosis. Insulin, right. I'm teaching to a crowd that should have warned me beforehand. Okay, so treatment-related neuropathy, yeah, also known as insulin neuritis, although that's not appropriately worded, as I'll explain in a minute. So the risk factors usually are patients with poorly controlled diabetes, especially with type 1 diabetes. Those who have diabetic anorexia, so people who use insulin for weight loss, are particularly at high risk of getting this. Yeah, and the symptoms are, as described in this case, is a diffuse pain, usually sensory, very painful, following rapid glucose control. And autonomic neuropathy can also happen in them, and the symptoms just improve over months. Yeah, it may recur if the diabetic control lapses and is again controlled rapidly, so it can recur with the same cause, rapid correction of glucose. But there's no histopathological or CSF evidence of this being inflammatory or autoimmune, but when you look at the skin at the nerve biopsies, they actually look vascular. So you wonder whether it's a vascular etiology, and they're associated with progressive retinopathy and diabetes as well. So that's why insulin neuritis is not an appropriate term, because it assumes that it's an autoimmune or inflammatory process. It's actually vascular. There's another interesting one called the insulinoma neuropathy. This happens in people who have chronic hyperinsulinic states, and they have repetitive episodes of hypoglycemia. And when you have protracted repetitive episodes of hypoglycemia, you can get this kind of neuropathy as well. So distal paresthesia, you don't have much to find, and it's usually more in the upper limbs than the lower limbs, and you have significant proximal weakness, and foot drop is common. And usually if it is an insulinoma causing it, then this tend to get better as well. I think this is rare, but just something to be aware about in your patients. Right, so this is one of my patients. 67, type 2 diabetes for 12 years. Progressive inability to walk for the last 3 months after he was admitted with an upper gastrointestinal bleed. In this 3 months, he's also got shooting pains in the legs and in his back, and he's got numbness in his feet. He's lost 40 kilograms in the last year, which he says is because he's been a bit anorexic. On examination, his left leg is completely wasted. Particularly the quadriceps and the hamstrings, power is 2 out of 5, and the remainder are still weak, 3 to 4 out of 5, and his reflex is not present. The right leg is not as bad. He's got decreased pinprick and temperature sense to the mid-calves with decreased vibration. He has nerve conduction studies and EMG that show absent nerve responses, and he's got diffuse, what we call neurogenic changes, Also in other nerves outside the leg, so thoracic and lumbar spinals as well. So a diffuse kind of neuropathy affecting thoracolumbar areas. Diagnosis. Diabetic amyotrophy. Yeah, there's only 2 people shouting on answers. But yeah, you are right. What's the other name for diabetic amyotrophy, Dr. Jacob?
Neuropathic cachexia.
No, that's a different condition.
Oh.
Oh dear, what about it? Okay, so one of you, the proper term is actually diabetic lumbosacral plexus neuropathy, or DLRP.
Why should you remember that?
Also known as diabetic amyotrophy, but that's the proper word. Okay, so amyotrophy just means that your muscles are getting wasted, which is why it's not the term that we use normally. And it is usually unilateral, usually thigh pain, moving proximal. You get a deep aching and burning and tingling sensation, and it progressively atrophies and gets weak. Rarely does it go over to the opposite side. In my patient, it actually did, but not as much. Interestingly, you also get thoracic radicular pains, and those are usually pains that go around like this. Yeah, so on one side or the other, you get this chest pain as well with it. Most experience this dramatic weight loss leading up to it. It usually happens in older people with type 2 diabetes who have diabetes for shorter duration comparatively, and also have a not too badly controlled diabetes as well. Okay, and it progresses over several months, and then it follows with a gradual improvement over time, but they don't get back to what they were at before they got ill, and many of them are rendered wheelchair dependent. Okay. If you do investigate, lumbar punctures do show an elevated protein, doesn't mean much. However, it's important to do that because there's some evidence that you can immunosuppress these people. Not because it helps them get better quicker, but because the pain is really better controlled with sort of 3 months of prednisolone. Yeah, then you can just taper off after that. So there's some evidence for that. And before you do give someone steroids, make sure that the CSF is not active. So that's DLRPN. It can also happen in the cervical region, so it's called DCRPN, if it happens in the cervical region. So the arm is affected instead. But so this is one example of what we call an acute diabetic neuropathy. And they're usually rare, but they are dramatic and disabling when they do happen. And I remember our patient very well from that. The one you were discussing, the diabetic neuropathic cachexia, it's quite similar to the insulin neuritis. But in addition to the severe acute painful neuropathy, you get this unintentional weight loss, and also can be provoked by this rapid glycemic control. But one of the clues that give this away is that the pain is usually not length dependent. Yeah, it's just like that for the lady who had an HbA1c of 12. Yeah, this one can be generalized. And the clue sometimes is if you get this pain and numbness and sensations on the trunk or the torso, that gives this diabetic neuropathic cachexia because it affects all the nerves. And the pain peaks with the weight loss, and it's very hard to control, but then it gets better again over time. And it does improve spontaneously, and the therapy is mainly supportive, so pain control. Okay. So, this is my last case, just so that we are all aware about what I said at the beginning of the talk. Always consider mimics. 45-year-old female, 3 weeks of sweating a lot, weight loss, 2 weeks her left arm and then her right leg are becoming numb, it's getting progressive. When you examine her, the left radial and ulnar nerves are weak, power 3 out of 5. She's got a right foot drop with a L5 distribution dysesthesia, and she's got reduced ankle jerks and supinator jerks as well, and you do some investigations, and the ESR is raised at 68, and the CRP is raised at 120. So,
myeloma or agamopathy?
Myeloma, gamopathy, so what are you thinking? One of them. But what kind of condition is this? I mean, this is a... Okay, but let's go back to what I first told you. So when someone comes with a neuropathy, there's 6 questions you have to ask. And one, we know the chronicity of this is quite acute. We know it involves both motor and sensory. But what else is interesting about this one? It's patchy, yeah? So it's an asymmetrical, yeah? So it's on leg, arm, on opposite sides. So what does that sort of narrow us down to? Neuritis multiplex, okay? And the point here is that this lady did have an ANCA positive vasculitis, okay? Just because someone's got diabetes and they get a neuropathy doesn't mean it has to be due to the diabetes, and keep your mind open about the other neuropathies that can give you this kind of picture. So asymmetrical neuropathy with motor sensory signs, you can do a host of tests, but indeed the vasculitis screen, as was mentioned earlier, is indeed very important in these people. Okay, so always consider mimics in people who have diabetes, and in fact that is the hallmark of when people present to you with peripheral neuropathy in terms of excluding other causes. I'm going to end there. We're just summarizing the things I've hopefully taught you in terms of neuropathy and diabetes. So neuropathy is a common problem in the world. The pattern recognition is important. I've told you the 6 key things you need to look at. So the types of systems involved, motor sensory, autonomic, the distribution, distal, proximal, asymmetrical, the time period, is it acute or chronic, is there any open neuron signs, and that's important because that pigeonholes patients into different kinds of categories. In diabetes, we can further, again, just the specific diabetic neuropathies, you can classify them into the chronic forms, which is the more common one, and the rare acute forms, which we've talked about. So the diabetic amyotrophy, the cachexia, and the insulin neuritis. They are rare, but they need to be known about. And they have those different types have their distal distributions as well. Yeah, so they can be mononeuritis, such as the carpal tunnel syndrome of the lady we first saw, or the polyneuritis, which can be asymmetrical, or indeed the commonest one is the polyneuropathy, distal sensory polyneuropathy in diabetes. There are essential investigations you must do in all these patients when they come to you, particularly with your box standard peripheral neuropathy patient who's got diabetes. Make sure, apart from looking for diabetes, do the oral glucose tolerance test, do a serum electrophoresis, or ideally a serum immunofixation, and send the urine residence proteins in case they have a paraprotein in them, because that's treatable. Management of these, although you can find all these problems, it's usually supportive. It's pain. Steroids has a very small role, but if you find something that's treatable like a vasculitis, then you can treat it. And on that point, I'll end. Thank you.